Welcome back to On the Edge. I'm Dr. Jonas Moses. This hour, a special report on public health policy and infectious diseases. During the commercial break, I asked my guests a question on that issue of the larger population. As patients, at one time or another, all of us might go into a clinic or see one healthcare professional or another, and in the absence of any real direct isolation of a disease, of an infectious disease process, we begin treatment. As I said, in the United States, in the Western world, we have some checks and balances. Someone in our lives who's saying, wait a second, you should get a second opinion, or wait a second, see another doctor, or wait, here's a specialist who can really help. But in most countries in the world, outside the first world countries, which represent the lion's share of the billions, 7 billion people in the world, there is no advocate for the patient. So, Audrey, you wanted to pick up on this.
Yes, there's something really important to do with the medication and in relations to the diagnoses and so forth. Even if someone's been diagnosed with HIV and they're being treated in a clinic for it, according to what I learned during my nightmare with it, after finding out that I was negative in false diagnoses and that sort of thing, I learned that a person should not even be on the cocktail or the drugs or AIDS drugs of any kind unless they go below 200. In my case, I never reached below 200 according to my records, yet when I first found out, they had me on the drugs, which was killing me. Ultimately, it was the drugs that were killing me, as we obviously know, and proof positive.
Okay, I want to pick up on that really quickly. We have a limited amount of time, but I do want to point out, because I wanted to do my homework here, and I knew that you had been treated with AZT, and I just want to read what I learned. AZT is a highly toxic chemical compound originally created for use as cancer treatment. It's a no-nucleoside analog drug or a DNA chain terminator, meaning that it stops DNA from replicating. Ultimately, it therefore destroys all growing cells in the body, and that it includes new cells produced in bone marrow where the immune system is generated. In 1964, experiments with AZT on mice with cancer showed that it was so effective in destroying healthy growing cells that the mice died of extreme toxicity. As a result, the drug was shelved and no patent ever filed. And yet 20 years later, this same drug was resurrected and remarketed as an anti-HIV drug. So my question is, one, how does something like this happen? That a drug
Broder did it in his deliberations, and okay. When Harvey Bialy was sitting next to him,
who was Harvey Bialy?
He was the former editor of Nature Biotechnology. He started the journal.
Okay.
He thought he was sitting next to Goebbels because he knew the toxicity profiles of AZT, and when he showed them, he was ignored, and they used it anyway, and they passed it in a record 4 months.
And this was in 1984, 85?
1987 official trial, when they showed that all the patients were dead after 3 years that were on it. Great drug, I say. I mean, but nevertheless, it became the mainstay for treatment, and it corresponds to the overwhelming death rate of the gay population. Essentially, it was a systematic genocide against gay men of that period.
Okay. You're not sugarcoating it, are you?
Yeah, I'm not sugarcoating it.
I don't want to pull any. What I don't want to do is assassinate any one drug group or anything like that. What I want to do is I understand that, but what I want to do is point up. The conversation I want to have for the rest of the program here is about what we can do differently now. Plainly, some of these efforts were well-meaning. People were trying to help patients. They're trying. All of these organizations, I have to believe, in their heart of hearts, the physicians, the research scientists, the drug companies, all want to help folks.
Well, I'll tell you, to answer your question about how did that happen in the first place, it happened because of something we call tissue culture data. In other words, we were seeing, again, molecular phenomena at the molecular level, and tissue cultures, and that's where it appeared that there could be a positive effect to this molecule, regardless of how toxic it was. That is what justified the trial itself.
Okay.
Perhaps we need to have a little more stringent animal testing, for example.
Right.
But we already knew in this case that this molecule was toxic, and it wasn't that important. So that's one problem, is that we are eager to jump into these clinical trials, and then we're also eager to halt them early on the basis of what we perceive to be beneficial effects.
Okay. So studies should be going longer than they are.
Of course, they should enroll more people. They should go longer, and there should be, as you mentioned, your T cells never went below 200. Okay, that's what this drug was approved for.
And that's why.
Yeah, and the Department of Health and Human Services, at the same time that you were being treated, had recommended 1,000 or even more than 1,000. It was an aggressive campaign that became known as Hit Early, Hit Hard. That's what was really harming
and the name,
people.
David Ho was the name.
Okay,
that
but
came up with that.
that's where the damage was coming from.
Right.
Is off-use, off-label use.
Yeah. Well, that's why I wanted to bring up that, because I think it's so important for other people out there who don't know this information. You know, if their counts are not below 200, then they should not be on the cocktail, according to the CDC.
All right.
Okay, and
this one particular disease we're talking about.
Yes, in HIV/AIDS diagnoses.
Okay.
If their count is not below 200, according to the CDC and all the research that I've done myself, they should not be on the cocktail.
Well, good point. And everybody is back.
You know, a lot of people don't know that, and then they get sick. If they're not already sick, then they get sicker from the drugs, and it's not actually from the illness, it's from the drugs.
Okay, so constructively, again, I want to come back to this. Constructively, what can we do now?
Well, the first thing to do is reappraise these diseases and their so-called causes.
Okay.
That's the first thing that should be done.
So we need a
wide
continued
scale.
dialogue.
On World AIDS Day, we came up with World Reappraising AIDS Day. Okay. And it got wide press because we want to review the data that led to these public mandates, public health mandates, and we want to do it perhaps in Greece in November in a large debate between the two sides, as we did in Durban in Africa. That's the first thing.
So you're saying
we'll go there. We're going to take a commercial break. You're watching On the Edge. I'm Dr. Jonas Moses. With me this hour, Dr. Rodney Richards, Audrey Serrano, and Dr. Andrew Maniotis. Stay with us.